played important role. Played an important role in oncology since first radiopharmaceutical started to be used in clinical practice. Maybe since 950 or last century. Um, so our main uh, yeah, our main issue in breast cancer, not to diagnose, to be clear, to be frank. So we are contributing to some extent in primary diagnosis, but mainly we are uh, receiving the patient after diagnosis. We have a package for the patient, breast cancer patient, starting by uh, uh, doing some images to uh, as, assist or help assist the surgeon to go further for surgical treatment. So we are we have a main role in staging, uh, in initial staging and restaging after initial staging by other modality. So we can restage again the situation or the status of the patient. Also, after completing the therapy, we can evaluate the response to the therapy. And even sometimes after maybe 2 to 3 cycles after treatment, we can make a study and we called it interim to see where we are. Are we going well, or we have to change the protocol of treatment? And also, after completing the response, completing the therapy, we see the response, and we can follow the patient to see if there is any recurrence in the future. Besides the evolution of radiopharmaceutical, it's most important to note that the equipment progression also in last 2 decades uh, help us well in specific or precisely localize the lesions, either in the breast or in locoregional metastasis or distant metastasis. That era or this new progression in making the study not only conventional planner, no, SPECT and SPECT CT, three-dimensional images. So it was not available before in nuclear medicine. So the improvement in these equipments help us more and more to improve the sensitivity of our scanners. So we can summarize our the other thing to do multigated angiography to see the accurate ejection fraction of the breast cancer patient. So before starting the anthracycline and trastuzumab, which they are known cardiotoxic drugs. Also, we do bone scan to check for um, uh, osteoplastic lesions that denote metastasis. And it was in the past only by single photon imaging by methylene phosphonate group. But in 1980s and after, another tracer, which is sodium fluoride, give us a very good images, as we will see sharp. And also lately the introduction of very important study, FDG, PET-CT, help us more and more in this staging and restaging and detection of recurrence and follow up the response. And we will talk briefly about uh, positron emission mammography, which is available but not in many of institutes. So regarding lymph node scintigraphy, we have to determine the lymph node status via biopsy and, predict nodal involvement with high accuracy. We need to exactly see the sentinel lymph node, which is the first and the hottest node that appear after injection of radiotracer to يعني give us أو help us in avoid the comorbidity from lymph node dissection. So histopathological negative sentinel nodes implies that the ipsilateral node bed is free from metastatic disease, spare cost and comorbidity after dissection. So our study is dynamic. After injection, the material, which is radio-labeled colloid, give the serial map about the status of nodes. So we inject the tracer by two techniques, either periareolar or peritumoral. So as we know, if we inject periareolar, which is superficial, so there is rich lymphatic subareolar area or subareolar plexus, which we quickly visualize the drainage channel. But if we inject it peritumoral or deep, so it will take time to appear this sentinel node. But we can see a specific أو accessory drainage pattern. We can see intramammary chain, which will change the management of the patient surgically or regarding radiotherapy. So our technique in injection differ between both, but we prefer this superficial. In our department, we use superficial injection and we find the sentinel area and help the surgeon to see the or to detect this sentinel node. As we lymphatic transport of radiolabeled particle after injection can be influenced by particle size. These colloid particles is albumin colloid. So it is micrometer, nanometer to micrometer in size. So propagation of this particle in the lymphatic channel, it is according to the size and the dose. If the size is large size, so there is slowness in progression. So it has advantage and disadvantage. The slowness can give us time to detect the sentinel. If we inject the smallest part, so the propagation will be very fast. We cannot catch the sentinel. Exactly. So that means when we start the acquisition of image, we will find many nodes. So we cannot uh, exactly determine which of them is a sentinel. So we start by planar acquisition normally, and it will give us the map of the area of the station of the nodes or the node basin. And then after that, we add spec CT, which will give us exactly the level of the node, either auxiliary level 1, 2, of nodes. Uh, uh, so after imaging a patient, we do marking, and uh, in the theater, the surgeon can use, or the nuclear physician accompanying the surgeon can use the audible gamma probe, which exactly uh, count the radioactivity. So the area of the very ample amount of count, which is the area of or the node of or the sentinel lymph node. Okay, now we can see this is a planar image of sentinel lymph node. As we can see here, this is the node here. Uh, Let us uh, talk about the injection technique briefly. We inject in 3, 6, 9, 12 clock stations around the, as we said, periareolar or peritumoral. So we can find here above 12 point, we can see the sentinel node. And if we shift the or move the detector, we can find at right anterior well here, sentinel, and at right lateral position, we can see it here. So after doing spec CT, we can see the node is here uh, at axillary level 1, lateral to uh, pectoralis minor. Okay. Now we will talk about multigated radionuclide angiography. Uh, so to the myocardial muscle, affect the myocardial muscle. So can cause cardiac failure, heart failure, and may lead to death. So before starting the chemotherapy, we have to do multigated angiography or megascan, well known by megascan. Um, Another issue that can cause cardiotoxicity apart from or affect the left ventricular function is the pericardial effusion or the pericardial irritant. This drug can cause, or the radiation therapy, sorry, the radiation therapy can cause pericardial irritants. It will affect and cause pericardial effusion and will affect the ejection fraction and uh, uh, ventricular function. So, MAGA is regarded gold standard to measure cardiac function with high accuracy and low inter-observer variability. As we know, with echo, which is operator dependent, we can we it will be there is inter-observer variability between cardiologists and other or technologists and other. So MAGA is so accurate in ejection fraction assessment. It is non-invasive technique, very important. Only injection of radioactive material, uh, which is perticnetate labeled to the RBCs labeled with perticnetate. We labeling the RBCs with perticnetate and injection as a bolus dose. So we can assess the wall motion, we can assess the ventricular systolic and diastolic function, we can assess ventricular ejection fraction and ventricular volumes. So this labeling, many technique of labeling, of RBCs labeling. And this technique determines the labeling efficiency, which is in vivo or in vitro. So we use in vivo technique, simple technique, labeling efficiency more than 75, which is good. And we will show us the left ventricle. So after pharmaceutical administration, we do planar, spec, or combination. Planar must be doing in views, anterior, lateral, and very important view is left anterior oblique with caudal tilt. This will show us the left ventricle clearly, so we can determine the motion. This we can do, which is called gating. As the study will be gated, will be cinematic display. We can see the moving heart to see the contractility and see the volume of the left ventricle. The result is seen image. Here's the image of MAGA scan. You can see here the left ventricle separated from the other rooms of the heart at diastolic stage. The volume here is as much as it can, so decreasing up to the 8th frame. We can see the left ventricle here very small. So again, after end diastolic, we can find the volume uh, uh, at end diastolic time. These are parameters which was called objective results of the study. We calculate the left ventricle ejection fraction by draw around the left ventricle during diastole and during systole. Deep as much as the ejection fraction is good, and we are okay. So I think in this patient, the ejection fraction more than 50 something, which is good to start chemotherapy and monoclonal immunotherapy. We have we have to make synchronization between R interval and acquiring the frames. So between RR, we acquire about 16 frames. As much as we acquire more frames, as much as the image will be helpful, and we can calculate the ejection fraction good, and we can see the motion and contractility. Okay. We see here a deceased patient or patient with heart failure or with dilated left ventricle. So no change in the volume of the left ventricle, sorry, between diastole and systole. All images is the cursor left ventricle here in end diastole, and if we count 8 frames, here it will be the end systole. The volume also is the same like end diastole. So there is dilated heart and absolutely very bad ejection fraction. The third study we do in our department for breast cancer patient, bone scan. Bone scan either by single photon tracer, which is phosphonate, MDB, or by, as we said, fluorine 18 sodium fluoride PET tracer. So MDB used for seeking out to localize the site of increased perfusion and bone turnover, making it highly sensitive tool for detecting osteoplastic, lytic sclerotic. So I need to verify issue here. So we see osteoblastic lesion. Always see osteoplastic. We can't see lytic lesion.
The mic, so we hear you better.
Okay.
Okay.
Now,
Yes.
how is now?
Yes.
Now
Now we
it's
can
good.
hear you. Yes. Now it's
Good.
good. Thank you.
So we said that the osteoplastic we can detect by MDB osteoplastic and sclerotic mixed lesions. We can't see lytic lesion of the bone itself. So we use bone scan for initial staging. Evaluate evaluate even degenerative changes and cysts, other benign lesions than the and differentiate it from the metastatic deposit. Also, we need to verify something which is called flare phenomena, which is characterized by increased radiotracer uptake as a result of therapeutic increased osteoblastic activity, denoting there is a healing bone, which is good sign. So we can confuse this flare phenomena with new lesions or aggressive lesions that going with the worst prognosis of the patient, but no, it's flare phenomena. So we have to be sure about this issue. Typically between 2 weeks and 3 months after chemotherapy is a normal picture of bone scan, anterior and posterior, whole body bone scan by MDB, showing us normal uptake in the sternum, in the iliac wings, in the ribs, left 7th rib, and anteriorly, and right ribs posteriorly. And also we can see here right sacroiliac, it's iliac iliac crest, posterior superior iliac spine في junction with sacroiliac joint, right sacroiliac joint. If we, and this patient have many osteoarthritic changes of knees and of ankles and to some extent of shoulders. When we did the SPECT CT for this patient, we can see exactly the site of above mentioned lesions of right here, right sacroiliac, right iliac as a sacroiliac junction, and anterior superior iliac spine. Same patient, after SPECT CT, we can detect lesion not appear in the planar image in the first lumbar vertebra, vertebral body, uptake the tracer and appear sclerotic in the corresponding CT, which is low dose CT, only for anatomical localization purpose, not for diagnosis. Another tracer lately used in nuclear medicine department, sodium fluoride, we call it NAF, and acquired by PET CT camera. This radiopharmaceutical chemo specificity than bone scan due to higher target to background ratio and to the technological advantages of PET scanner, which acquire two photon and highlighted from a positron. So the resolution and the quality of the image is very, very better than single photon image. As we can see, the same patient, regardless the deposit, the same patient is image in the up images with MDB bone scan. So we can now notice the clearly difference between two images, the quality of the images. So NAF is help us more and more to detect the metastatic deposits. Coming to the very important study in nuclear medicine department, PET-CT with the FDG tracer, deoxyglucose, F18. You can see here the mechanism of uptake of this FDG or the behavior in tumor cell and compare it with normal glucose. It is fluorodeoxyglucose. So we can find that the FDG enter to the tumor cell but cannot go out. Okay, this is the first thing that a tumor cell can avidly uptake the FDG. The other thing, after uptaking inside the cell, phosphorylation by hexokinase occur, but dephosphorylation by G6 phosphatase minimal, not like phosphorylation. So after phosphorylation, the tracer will remain inside the cell more than normal glucose. And last thing is cannot enter the glycolysis pathway, will trapped inside the cell to give us clue about the cell, or to after that we image this cell and we can find a neoplastic cell easily with FDG. So we correlate with cellular metabolism and most widely use radiopharmaceutical for PET imaging this FDG with breast cancer patient, indicated for staging, restaging, evaluating the response to treatment, and detection of recurrent disease. So we don't have role here for diagnosis, to be honest. Staging, restaging, evaluating the response, and detection of recurrence. So with high sensitivity and specificity, we can find extra-axillary lymph node metastases, and especially in internal mammary chain, which will change the protocol of treatment of breast cancer patient. Okay. Also, regional lymph nodes is suspected by FDG. We can find axillary level 3, infraclav, supraclav, and internal mammary. All will change the treatment decision. Overall, FDG is superior to imaging in identifying occult distant lesions, mainly bone metastases. As we said, lytic metastasis, lytic bone metastasis, not sclerotic. So the cocktail of two studies, NAF and FDG, can clarify the bone, can clarify the lesion in the bone, either lytic or osteoplastic or mixed. We can detect any bony lesions. Okay, now we will go to the recurrency of the treatment. If we do another image and we are doubtful, or there is a rising in tumor markers, or any suspicious of recurrence, we can do F18 FDG PET-CT. Then we outperform conventional imaging in detection of either local regional or distant recurrent disease. Okay, also, last but not the assessing of response to therapy. Uh, as we said early, prediction of pathologic complete response in leukoregional, while metastatic disease, it offers good performance in evaluation. Better to do FDG after 3 cycles to see are we going well with the treatment or changing the plan of the treatment. Uh, Normal FDG, PET CT scan, maximal intensity projection image, we see that the normal biodistribution of our tracers by brain tissue, by myocardium, liver to some extent, and tonsils, and bilateral kidneys and bladder, which is the root of tracer excretion. Breast cancer patient after PET CT image, our primary appear well. We have to describe the lesion if we have cross-sectional image, axial, to see the characterization of the image anatomically. Skin involvement and multicentricity, and like so. Here we can find the primary, and we can see the primary, and we can see the axillary lymph node, secondary area of uh, neoplastic spread. Axial view of PET CT image showing us the tumor exactly in the right breast with most likely multifocal tumor. We cannot see lymph nodes here because I don't think is a level of axillary and even internal mammary. Another image of FDG PET-CT detect the activity in speculated mass in the here we can mention very important things that we have to exactly read the metabolic activity of the lesion, by which is called SUV, standard uptake value. So we will follow the patient according the baseline SUV max. So we need to exactly measure the SUV max of any lesion uptake the our tracer. Okay. So it will not confuse you this image. The primary is not in the best. Definitely, the breast take the tracer avidly during hormonal changes, during cycle or like that. So it is physiological uptake of the tracer in breast bilaterally. But the primary here in the neck, which is a case of lymphoma, left cervical uptake at amalgamated lymph node. Okay, last thing is a new era of using F18 FDG in cancer and use a new advanced machine, which is positron emission mammography. So we use the same tracer, fluorodeoxyglucose, deoxyglucose FDG, and image in and in machine has a characteristic of imaging the breast in prone position and using which is uncompressible hanging breast in prone position using ring shape scanner with a small field of view and breast position between compression bodies. Has an advantage that its diagnostic accuracy is not affected by dense breast tissue, but or menstrual cycle. But the disadvantage is that has a limited field of view. The field of view is limited. Can miss a small deeply located lesion closer to the chest wall. Okay, centimeter closer to the chest wall, we can miss it. Okay, or next to pectoral muscle, or at axillary region. Uh, honestly, I don't have experience with this machine and with these images, so I don't know much more about it. Here we can see the image of BEM lesion in mammogram. Uptake the tracer here in the positron emission mammography images. Thank you so much for your attention, and hopefully you get benefit from this brief talk about role of nuclear medicine in breast cancer patient.
Thank you very much, Dr. Yahya. It was really beneficial and interesting lecture. Thank you very much. And excuse me to delay the questions and comments after the last lecture. So we will proceed for our last lecture, which will be about multi-modality approach for breast cancer case dissertation, and it will be introduced by Dr. Rabab. يعني عايزة أقول حاجة بالعربي إنه يعني رباب بدت لنا سيمبوزيوم وحتختموا لنا إن شاء الله، فإن شاء الله يكون مسك الختام. You are welcome, رباب.
شكرا وشاح، جزاك الله خيرا على الكلام الطيب، برضو بالعربي زي كلامك يعني، لأنه دايما العربي كلامه طيب أفضل من اللغات الأخرى.
الله يبارك.
بسم الله الرحمن الرحيم، وبه نستعين، والصلاة والسلام على أشرف المرسلين سيد الخلق أجمعين. First of all, I would like to thank Dr. Yahya for his excellent, skilled, capable presentation. Okay. Good evening, everyone. We are pleased to welcome you to the final session of the fourth SSBI Radiology Symposium. It will be about the multimodality breast imaging correlative approach case discussion. Nice to see pink everywhere. As we always say, the mammogram is like the first chair, the ultrasound is the second, and the MRI is the third chair in the orchestra of breast imaging. Let us take a short journey together to explore their companion diagnostic performance. Starting by this first case, and a 49-year-old male presented with left nipple bloody discharge. He has history of recurrent third ventricle brain tumor that can result in persisting estrogen-androgen imbalance, most likely accounting for the bilateral breast proliferative changes. Let us see his imaging. Starting by ultrasound for that male, demonstrate bilateral ductectasia, which appear to be complex, demonstrating internal echoes, and in the left side, also associated with calcifications. We proceeded for a mammography, and the mammography demonstrate bilateral ductectasia, and sorry for the image was not performed with a high quality, but there was faint punctate calcifications on the left side. And interestingly, the ductectasia on the right side demonstrate low density X-ray appearance, which reflecting predominant internal echoes seen on ultrasound representing a lipoproteinaceous material. We proceeded to MRI, and the MRI demonstrate or confirmed the bilateral ductectasia with high T1 intraductal component in the right side following the mammography appearance, and intermediate to low density in the left side. And in post-contrast, there was predominantly preductal enhancement on the right side, but clump ductal enhancement on the left, and to lesser degree also seen on the right side here in the subtracted images. In the subtracted images, the ductal clump enhancement is much more clearer. See, you can see it here. Sorry, it is a native, it is not subtracted, it is a native but fat suppressed image. Sorry for confusion. This is the clump ductal enhancement on the left, and here on the right side. And their kinetics, it was a plateau and delayed washout on the right, but it was a washout in the left side. So findings are suspicious of ductectasia. But unfortunately, we didn't get the final post-operative result. This is another patient, a Sudanese lady, presented to radiology department with this fungating mass. Okay? For radiological evaluation, she was lactating, and the surgeon requested ultrasound evaluation. So our ultrasound here demonstrate this mass, but it is strange. That mass, it is well delineated posteriorly here, okay? It is lobulated, and it seemed to be like swollen fat lobules. Can you see the fat lobules here within the mass? These are the fat lobules. And when we trace, we could see also two convergence. As you know, the ductal convergence, the normal ductal convergence from the whole breast radiating toward the nipple. But in this patient, I could appreciate it. I have two ductal convergence. One ductal convergence normally pointing toward the nipples with dilated fluid-filled ducts because she's lactating and she had an active lactational breast changes with increased vascularity and ductal dilatations and glandular background ground glass parenchyma. So that attract my attention, the ductal convergence toward that lesions and the underlying, and even within the lesion itself, what I could appreciate is only fat lobule. I was thinking that a bulging breast tissue getting outside the breast. I trace it and I could see the defect here with the adjacent skin swollen, okay? Swollen adjacent skin. Here, this is the mass, and here, that is the defect, okay? Again, here, this is the mass outside the skin, and at this area here, there is defect, and there is continuation between the mass and intramammary tissue, the tissue between the tissue outside and inside the breast. There is a communication between the two, as you have seen here, associated with edema and even the vascularity. Look for this vessel passing from the inside intramammary to outside into the mass. So I was so surprised because it was my first experience to see a breast hernia. I asked the lady, do you have any trauma? She answered me that yes. She has a history of hitting she fell down, and she has a history of hitting of a hard object. So I called the surgeon and told him this is a breast hernia. He told me that I have never heard about a breast hernia. There is nothing in the literature like that. I told him, yes, for me, it is my first experience. Let me go, and the patient not prepared, but let me do at least MRI, anatomical sequence, to see what is going on. And this is her MRI, okay? Just pre-contrast T1 and T2, and these here are T2 images, demonstrate the floor-like, the hernia, and the continuation between the herniated breast tissue and intramammary tissue. Can you see it here also? These are the ducts converging into the hernia, okay? These are the ducts converging into the hernia. And if you compare the two breasts, okay, the left breast is smaller compared to the right breast because some of the breast tissue exposed, extending outside through that defect and reducing the volume of the breast. And there is also bilateral lactational breast changes. I have to notice that there is background inflammatory process in the underlying breast. Okay, if you look here, this portion of the breast is normal, while here there are a lot of changes, which was seen also in ultrasound, and we report it as a left breast hernia, okay, radiologically, post-traumatic in nature, and associated with underlying mastitis and possible fat necrosis, okay, in a background of active lactation. So the surgeon told me I have taken biopsy, sent to the pathology, and sent the patient for you for the evaluations. And after 2 days or 3 days, he sent me. He has sent me the pathology report, which was proven to have inflammatory ulcer and lactation breast changes within that herniated breast tissue. Okay, let us go for the next patient. A 56-year-old female asthmatic patient received a high-resolution CT chest to evaluate her chronic asthma, acute attack. Okay, so incidentally discovered a right breast mass in her on her chest CT. If you look for the mass here, you might say that this is a benign looking mass, probably fibroadenoma. But because this is not an optimum modality to evaluate the breast, they have sent the patient to breast imaging evaluation. And here we can see her mammogram demonstrate a mass. Okay, this is the same mass seen in the medial breast, but appear probably indistinct in a background of heterogeneously dense and complex coarse parenchyma. And again, here, this is a mass in the inferior breast. It is in inferior medial breast about 4 o'clock. But if you can see closely here, okay, in a spot magnification view, we can see as if there is a capsule and underlying lucency within the mass, okay? And even there are patches of lucency seen within, okay? Suggesting that it might be a fat containing like a lipoma or fibroadenolipoma or hamartoma, I mean. But if you concentrate at this posterior lateral portion, the capsule is incomplete, which is not a big deal to see a hamartoma without with incomplete capsule. But the tissue from this mass extending even beyond the capsule, which make it suspicious and associated with microcalcification that it arranged in a linear pattern that also upstage the lesion. So we proceed. Can you see it in more magnification view here? Okay, electronic magnifications. Can you see this linear calcification and extending beyond the level of the capsule? So this is her ultrasound. Also, the ultrasound appearance simulate a hamartoma, but it is not very typical. Not very typical of hamartoma. We cannot confidently say this is hamartoma and that is it. There is posterior shadowing. There is incomplete border. And as we have seen in mammography, I don't know, this is dropped. One of the images has been dropped. That is shown. Yeah, here also we can see the posterior margins is incomplete and some of the tissue seen of the same texture of the lesion seen outside, but obscured or masked by this posterior shadowing. Yes, this is the mass. It appears a little bit more heterogeneous and shadowing, and on elastography giving some hard elasticity. So radiological diagnosis is possible fibroadenolipoma with DCIS by Rad4C and we proceeded to MRI. This is her MRI, demonstrate the margins of which was non-circumscribed, and that is the extension we have seen on the mammography, demonstrate this linear non-mass-like enhancement. But there is, in the fat sat, there is, this is the apparent capsule seen on mammography, and the underlying lucency here, it is devoid or suppressed fat component. So yes, it is a lesion that contain minimal fat, but enhance on MRI, okay, and make it with non-circumscribed margin. So still it is presence of fat with these pictures. Still we report it as BIRAT 4C for biopsy correlation. But incidentally on MRI, we found a focal non-mass like in 12 o'clock. This is the focal non-mass like enhancement, the pink arrow. And here we can see this is the same 4 o'clock, our index mass we have seen on previously in the mammography and ultrasound. So we recommend biopsy of both lesions, okay? Sorry. Okay, MRI concordant with mammo sonogram, okay, suggesting of possible fibroadenolipoma with proliferative changes, most likely DCIS on top, and reported as BIRAT 4C, as we said, and also the 7 millimeter 12 o'clock lesion with rapid progressive kinetics, focal non-mass-like enhancement, okay, although demonstrate, no. Yes, sorry for confusion. Yes, it was type 1. It was type 1, but it is avid and rapid. It is avid and rapid, but it was persisting. It was progressive. It's seen at 12 o'clock. Okay, and the other findings, background fibrocystic changes. So the core biopsy of 4 o'clock lesion turned out to be grade 3 DCIS, while the incidental findings, 12 o'clock core biopsy of non-mass-like enhancement turned out to be grade 2 invasive ductal carcinoma, BR positive, HER2 negative, okay? And she was treated with nipple-sparing mastectomy. Post-surgical specimen confirmed invasive ductal carcinoma with DCIS and extensive background, usual and atypical hyperplasia and epicrine metaplasia. All lymph nodes were negative for metastasis, concordant with the imaging. The next case here, no, this is the same patients, just to show how the parenchyma was coarse as on the mammogram, okay? In ultrasound, it was also complex with areas, complex with patchy hypoechoic areas, okay, and excessive shadowing. And can you see it on MRI, how it is coarse here, okay, even in post-contrast and anatomical sequence. That makes the evaluation of imaging challenging, such type of the parenchyma. And can explain the excessive background or extensive background, usual and atypical hyperplasia. The background diffuse bilateral hyperplasia that gives that associated with such type of textures, okay? And here, this is the 12 o'clock lesions. You can see it on ultrasound here, okay? Also, it appears as in the ultrasound on MRI, seen as non-mass-like enhancement. On ultrasound, seen not typical of a mass. It seems as a patchy or a focal area of non-mass-like hypoechoic lesion. Okay. The next patient is a 58-year-old lady who had bilateral breast hamartomas for 18 years. Currently experiences pain in the left side of her left breast mass. This is her mammogram, demonstrate typical, so it is extremely dense, reduce the sensitivity of the study. Here we can see the typical appearance of a hamartoma on the right side, CC and MLO. But on the left side, I can see a mass, but it is not typical of a hamartoma. It was a hamartoma, but now it seems to be large, indistinct, high density mass, okay, which is suspicious based on mammography. And here I can see part of lymph node, also not typical. So ultrasound, it was the same, suspicious like on mammography. We proceed for MRI. On MRI here, we can see that is the right mass. It is typical of hamartoma, okay? And on stare and post-contrast, this is, it was fat, suppressed on fat SAT image, and the glandular portion intensely enhanced on post-contrast image. Here, this is with predominantly plateau kinetics. Okay, though few or small patches of washout seen within the lesion, but it was predominantly type 2 kinetics. Going for the left breast lesions. Here in this image, you can see both. That is the right one, and here we can see the left one, which appear micro-lobulated. And can you see the vessels, the large vessels going to that lesions? On here, it is low on ADC, denoting that suppressed on, denoting that on diffusion weighted, what we call and diffusion
Restricted.
restricted. Yes, it restricted in diffusion. Okay, and can you see it here in post contrast? It is irregular and even invading the adjacent skin. Can you see the skin here become irregular? The skin is irregular, and even by this, and even cause some contractions of the breast. And can you see the nipple? The nipple pointing because it contracted the breast, and it demonstrates some speculation and contraction and deviation of the nipple toward the left side. And here, this is the color-coded kinetics, demonstrate predominant washout. The red indicate washout kinetics, and the curve here is obviously demonstrate washout, rapid, avid enhancement, and washout kinetic consistent with malignancy. Can you see the lesion bulging beyond the skin and retraction, skin retraction, bulging, and without frank ulcers? So it was pathology proven invasive ductal carcinoma arose within a mammary hamartoma on 25th of May 2014. When I did search in the literature, okay, at that time, it was the case number 14 reported that invasive cancer arised in a hamartoma, okay? And hamartomas as per se are uncommon breast masses and typically benign and rarely develop into malignancies. In 2012, described 12 cases. Okay, K et al. He described 12 cases of carcinoma associated with hamartoma that have been documented in the literature. And in 2014, when we discovered our case, it was there was 14 reported cases. Our case, it was number 15, but unfortunately was not published. And in 2019, when I presented in a symposium, radiology symposium. I did another search in the literature, and I found only one additional reported cases added to the literature. Next case is the 36-year-old female. This is more interesting case, presented with a history of anemia due to vaginal bleeding. And they start to screen her by chest and by ultrasound pelvis, okay, which was normal. Then they proceed to chest and abdominal pelvic CT with contrast. And here we can see, obviously, her bone is studied with a lot of osteolytic lesions, and that compressed some of the bone and resulted in compression fracture or pathological fracture. These all seen in a 36-year-old female. She's young, but she had a lot of bone metastases throughout her body. And even on CT, her pelvic organs were unremarkable. This is a physiological cyst. Okay, so bone scan was negative. And I think might be expected in osteolytic rather than osteoclastic metastasis. Yes, it can be negative. Her CT chest, okay, when they discuss in the meeting, we raise some possibility of the left breast suspicious findings. If we compare the axilla on two sides, though are not bulky lymph node, but compared to the contralateral, there is asymmetry raising a suspicious features. And even the enhancement within the same lymph node appear non-homogeneous and nodular. And there is subtle perinodal edema, okay? And we said that there is nodular and asymmetric architectural distortion in the inferior medial breast, okay? Raising, so it appears subtle, not very convincing, but they recommended breast imaging evaluation. Here you can see the lymph nodes. Okay, can you see the lymph nodes in the left axilla and the nodularity and inhomogeneous enhancement? So the mammogram, the findings on mammogram were subtle, very subtle, passed as unremarkable by Radwan mammogram. But on retrospect, you can see here that what we pointed on the CT, you see the subtle architectural distortion, asymmetric architectural distortion. Can you see it here? This is the area of architectural distortion, asymmetric distortion. In the inferior middle, here on the MLO, on the CC appears central, but it was inferior medial towards central. And if you compare the two sides of the axilla, obviously this lymph node, though there is abundant central fatty hilum, but this is focal higher density region that can make element of suspicion regarding the lymph node. So the same radiologist performed ultrasound and reported as unremarkable. Okay, but if you compare the two sides here, definitely the left side, yes, it seemed to be hyperechoic or isoechoic to the parenchyma, but this is not typically normal. Okay, it is not a typically normal. Can you see here? This is the focus, hypoechoic focus, and as we mentioned in the previous lectures, okay, regarding the hyperechoic lesion is a deceiving, and we have to be cautious, especially if it is an ill-defined. We have to look for any hypoechoic needles within that hyperechoic area. And the lymph node, yes, it is not that, it is borderline. The cortex was borderline 3.5 millimeter, but it is deeply hypoechoic, and it is not as the same as echogenicity of the adjacent lymph node. So it is disproportionate locally within the same axilla and disproportionate with the contralateral axillary lymph node. So it is pathological. At least it is a pathological lymph node. And subtle perinodal edema with increased echogenicity in the surrounding tissue that reduce the tissue differentiations, fat tissue differentiation and its margins. Okay. They recommend biopsy in spite of benign reporting. When rediscussed in the MDT, we recommend a biopsy of that region and the lymph node. And the lymph node and the biopsy of both were negative. Okay, that is a biopsy from the breast lesions, and the biopsy from the lymph node was just a reactive adenopathy. Then MRI for the bone evaluation was performed and revealed these bone lesions highly suggestive of bone metastasis, and furthermore demonstrate arachnoiditis that suggests arachnoid metastasis. Okay, again, rediscussed on the MDT. And again, we raise the probability or the suspicious area on the left side along with suspicious adenopathy, and we recommend breast MRI. But the patient, okay, this is the area, but they started by bone metastasis, by bone metastatic biopsy, okay, or by biopsy of the bone metastatic lesions. And the pathology tend to be adenocarcinoma, but not clear the primary site. So proven to be bone metastasis, we have to search for the primary. Then they have sent the patient for us to do the breast MRI, and we could appreciate in the same locations here, that is the small lesion just abutting. Can you see it here? Abutting the chest wall and just attached. Can you see it? Very small. That is the one. It was about 1 centimeter lesion, okay, adherent to the chest wall muscles, and we raise the probability, and the lymph node also demonstrate focal enhancement within otherwise non-specific lymph node, raising the possibility that this is the primary site, is the left breast. But because it was very small, also not convincing for everybody. Can you see it here? That is a lesion. Okay. They proceed and recommend and they a PET scan for that patients. And fortunately, the PET scan not only demonstrate the bone lesions, but also confirm that the lesions in the breast was hypermetabolic lesions, taking the uptake of the material, as well as the axillary lymph node. Can you see? The same two axillary lymph node were in the imaging, okay, conventional and MRI raised as suspicious, were performed or were confirmed on PET to be highly suggesting of metastasis. And then again, they re-biopsied the axillary lymph node, and at that time we have one of the brilliant Sudanese pathologists. This image from outside Sudan was not in Sudan, but we had a Sudanese brilliant pathologist. She had done the second report and reported as a metastatic adenopathy from a breast with a molecular phenotype estrogen and progesterone receptor positive, HER2 negative. And the patient had received hormonal treatment and demonstrated remarkable improvement. Here you can see the shadowing from a nidus of breast cancer with abundant echogenic reaction. It is usually recommended to compare the two sides that can be easy to demonstrate that area is an abnormal rather than a normal one. Here you can see the same lesions in different images here in the CT. The first image, we raise the suspicions along with the mammography, and here the lesion, tiny lesion on CT and corresponding one on MRI, and the chest wall muscles was involved, demonstrate a focal enhancement. So in cases in which the mammographic evaluation is equivocal, targeted ultrasound or breast magnetic resonance imaging can be useful to exclude an underlying malignancy, and PET scan might be of help. The next patient here is the patient, 45-year-old female, complained of left breast lump for 1 year. And this is her mammogram. Demonstrate a segmental asymmetry. Within this asymmetry, there are multiple nodular densities and small masses, along associated also with calcifications, pleomorphic faint calcifications, as well as the ipsilateral axillary lymph node demonstrate a symmetric cortical thickening. So these are suspicious. And here the corresponding findings on the lateral aspect of the left mammogram. The right one was unremarkable. This is her corresponding ultrasound machine. Sorry for the low quality. The case was in Sudan. And that is the lesions, okay? This is one of the lesions we have seen in the mammogram, and that is the other one. Both, this is represent a complex cyst with a focal and mural nodule. The margin non-circumscribed. The other one, it is obviously seen here as the terminal duct lobular unit of a segmental duct, okay? And it is obviously, it has been replaced by irregular deeply hypoechoic mass, and the duct even is thick, dilated with expanding with a soft tissue material similar to these lesions. And not only that, one of the anterior lobular anterior lobules here can be seen even involved, and so forth. Here there is another one, and we can see this another one in the other image, and here there is another one. So, and this is another lesion here, very complex, soft tissue, cystic with cystic component. Okay, so to evaluate, we raise a suspicion this is BIRAT 5, but we need to do breast MRI before biopsy to evaluate for the disease extent. And here we can see the MRI demonstrate the same segmental ductectasia, okay, which is complex. This ductectasia, can you see the segment in the axial and in the sagittal T2, and here in and even, okay, this is the T2 non-fat SAT, and it seems to be very bright. The component is very bright, suggests that it is a cyst, okay, low on T1. But in both contrast, this is T2, multiple cysts. We can see multiple cysts within this ductectasia. But the both contrast image demonstrate clump ductal enhancement even within that cyst. And here we can see this cyst, okay, with a mural nodule, same as we have seen on ultrasound, and extending into the nipple. And that portion within the nipple demonstrate intraductal enhancing nodule, okay? Here, this is the same lesion, the index lesion. You can see it here, okay? Restricted in diffusion, okay? And demonstrate rim enhancement, okay? Rim enhancement, and it was so bright on T2, unusual, and for the malignant breast lesion to be bright on T2. And this is the kinetics for that, for the index lesion, demonstrate plateau kinetics. Okay, so the pathology report was concordant with radiology report, confirmed that this lesion was grade 2 invasive papillary cancer. Confirmed that it was multifocal as radiologically reported, and extensive moderate with DCIS. The radiology report was suggesting extensive multifocal DCIS with invasive cancer, which had been proven on radiology report, and also raised the possibility of lymphovascular invasion and involvement of pectoralis muscles along with ipsilateral adenopathy. Regarding the pathology report, confirmed the peritumoral lymph node lymphovascular invasion has been proven pathologically. But regarding the other findings, especially the nipple involvement and pectoralis involvement and such things, were demonstrated pathology radiology discordance. Okay, but as you have seen here, it is very obvious, okay, the dilatation of the duct within the papilla of the nipple with intraductal lesion. But the patient, this can be explained by complete pathological resolution, okay, following neoadjuvant chemotherapy. The patient received a neoadjuvant chemotherapy that can explain these resolution, pathological resolution of such findings. This is another patient, a 20-year-old lady presented with 2 months progressive left breast mass. As we have seen here, this mass, okay, it's related to the skin. It is a dermal lesions. It is indistinct hyperechoic, giving fusiform appearance or enlargement of the skin with multiple cystic changes seen within. However, it was not associated with ulcer, the epidermis was intact. What is your suggestion to be a diagnosis in such patient? Is it a benign or malignant, and what could it be? Do you have any suggestion for that? Do you have a suggestion? Any suggestion? Any volunteer? Okay. We raise it as suspicious for biopsy, and it was proven to be dermatofibrosarcoma protuberance, a rare type of skin cancer. Okay, can be missed as benign skin lesions. This is one of my interested cases. Okay, I miss it, but in the other way. It is as a false positive, not a false negative result, mammography or ultrasound result. If you look for this patient, we have here a very high dense mass, okay, engulfing the nipple. Can you see? With nipple retraction and associated with segmental nodular asymmetry in the upper outer breast. So confidently, I reported as BIRAT 5 for biopsy correlation, especially after I had done for her breast MRI. Okay, can you see the breast MRI? It was a complex, large complex, soft cystic with soft tissue component. Can you see the soft tissue component even lobulated, and even the soft tissue, the cystic component is of higher density, not even clear cyst. Okay, and in post contrast, the soft tissue component demonstrate enhancement, as well as those nodular segmental demonstrate also enhancement, and post contrast, and the kinetics was rapid, avid with plateau. So the morphology as well as kinetics were suspicious, as well as mammography and ultrasound. Okay, so confidently I reported as BIRAT 5, but tend to be just a papilloma. And after that, the patient brought this image 3 years before that study. Okay, demonstrate the papilloma that progress and engulf the nipple, but it was just intraductal, multiple intraductal papilloma, central and a peripheral one. This case, you can see here very obviously a fungating mass infiltrating, or a fungating mass related to the nipple enlarged and ulcerated. Okay, so there is a possibility of budget disease, and they send the patient. They have sent the patient for evaluation of breast imaging to exclude underlying invasive or DCIS. And if we look here, she was old lady, and her mammo was fatty, completely fatty, both sides, except for this asymmetry, okay, segmental asymmetry with subtle architectural distortion extending into the nipple. And you can see the posterior nipple, the irregular hyperdense mass, ulcerating mass. And as you know, 50% of cases with typical clinical features of budget disease had negative mammography findings, but this we consider it the other 50% that it is a positive. At least there is suspicions, and often it is associated with underlying DCIS or invasive cancer. And this is her MRI, confirmed the fungating nipple mass, okay, ulcerations, and the residual soft tissue intensely enhanced, as well as enhancement of that asymmetric opacity, demonstrates segmental clump enhancement, non-mass-like here, and it was proven to be a budget disease associated with essentially underlying DCIS. This is another patient of budget disease. If we compare the two sides, this breast, there is diffuse architectural distortion. This here, the parenchyma, okay, it is smooth with a smooth surface, but here a little bit distorted, and there is subtle skin thickening and retraction of nipple areolar complex. Can you see here, even associated with diffuse multi-grouped pleomorphic calcifications. And here we can see the ultrasound companion, okay, demonstrate these non-mass ductal-like infiltrative lesions throughout the parenchyma and malignant intramammary lymph node. Proceed to MRI, demonstrate frank diffuse enhancement, asymmetric to contralateral, the breast even a little bit enlarged, and these are clump, or though it is diffuse, but it is clump. And can you compare the vessels, the vascularity, a bit more compared to the contralateral? And within this, there is a mass. You can see it here. This is a mass, the largest one in contrast and post-contrast within this large infiltrative process in a budget. And this is another patient, our patient with budgets. Can you see, just presenting with these skin changes with intense enhancement. Here, this is the anatomical sequence, demonstrate the areolar and the medial skin thickening and band-like asymmetry compared to the contralateral side, which associated with this linear enhancement, and that enhancement here more thick and obvious in this area, along with enhancement of the skin thickening associated with plateau kinetics, proven to be budget disease with underlying DCIS associated with micro invasions. This lady presented with bilateral annoying nipple discharge, okay? Can you see how much is remarkable ductectasia? This is the right breast. Even there is cystic changes within this dilated duct. And this is the companion ultrasound image. Can you see here? We can see intraductal ball-like lesions within the right, markedly dilated right breast, okay? Although the left breasts are, the ductectasia is milder, but also demonstrate here very small area of internal echoes. We don't know these internal echoes are tumefactive, sludge, okay, or are intraductal lesions. Doppler negative. And as we mentioned, Doppler negative is not useful. If it is positive, it will help. But if it is negative, is not useful one, okay? And if we have a ductectasia, okay, or ductectasia is responsible for 41% of nipple discharge in non-lactating women. However, it is associated with etiology, okay, further, it is associated etiology require further elucidations. We have to clarify what is going on behind this ductectasia. So we proceeded to MRI. And the MRI here demonstrate what? High density material within, okay, these dilated duct, right and left. But here on the left side, it seemed to be focal, okay? But here, almost the whole duct contained proteinaceous high T1 material. On both contrast, the right one demonstrate no ductal enhancement, okay, no significant ductal enhancement, but the lesion on the left side demonstrate significant enhancement even with washout proven to be intraductal papilloma. The next case here, this one, we have to see the mammography, and I don't know why. The animation. Yes, sorry. Excuse me. It was animated, but for one reason, the animation, yes, stop. Okay, let us take it like that so as to save the time. Okay, this patient, I want to show you the first, the ultrasound, which was, yes. Okay, why? Okay, no problem. Let me again. Sorry for that. I don't know why it is not working. Yeah, at least one. Okay, no problem.
خدتيها في بلاي عشان تشتغل لك، ما انت حاسه ما
لا
خدتها في
انا
بلاي؟
ما هي انا لما خدتها في بلاي اتغير الثيم بتاعها كله، اتغيرت، اتلخبطت السلايدز. انا كنت خدت الالتراساوند، وراها المامو، وراها الدكتوجرافي، وراها الام ار اي، وكنت عامله انيميشن خلاص. but unfortunately الانيميشن اتغير، stuck also نفس الشيء. no problem. Okay, give me 1 minute just because it is also interesting case. If it work, yes, to show an ultrasound, because it was not, that is the ultrasound, okay? And here we can see, yes, here we can see الماموجرافي والدكتوجرافي. And then, yes. And then let us see the, بعدين نشوف ال MRI without. نشيل underlying animation. Okay. This 47-year-old lady presented with pain. ليش المشكلة؟ أنا ما شلت منها شايفة؟ Okay. Let us take it like this. Okay. طيب. Okay. طيب, no problem. A 47-year-old lady presented with pain in outer left breast and left breast nipple discharge. Okay. And here we can see this is just a segmental ductectasia, but if you concentrate as if there is soft tissue, small soft tissue component with this calcification, okay? And it was negative Doppler. So make it complex ductectasia. It's even if it is not complex, being segmental ductectasia, it is suspicious. And being associated with intraductal calcification, it becomes more suspicious. And associated with apparent soft tissue component that within which we can see the calcification, make it raise the level of suspicion. So we correlated with mammogram, and here you can see the asymmetric architectural distortion with segmental pleomorphic calcification, okay? More clear in the spot magnification view, okay? And this is the ductography of the same patient, demonstrate ductectasia, though it is a moderate type of ductectasia, but demonstrate beaded appearance and multiple filling defects within the main duct and its arborizations throughout, following the same area. And even here we can see the area of these interruptions in the ductal dilatations, okay, with the calcifications, which make it more suspicious. Can you see it here in these magnifications? This is magnifying. You see, can you see the filling defects and the calcifications along the ducts faintly enhanced because there are interruption here due to intraductal masses, okay? And these are multiple nodular filling defect and irregularity. So this is the MRI of the same patient, okay? The MRI demonstrates segmental clump enhancement following the same segment of the breast, our outer central breast extending to the nipple, and it was proven to be extensive high-grade DCIS treated with mastectomy. This patient have bilateral diffuse breast edema, okay? We don't know if it is systemic or due to underlying breast disease. Ultrasound demonstrate extensive edema with diffuse increased echogenicity, swollen fat lobules, subcutaneous dilated lymphatics, and fluid tracking into the interstitial fat planes, okay? Skin thickening, but suspicious axillary lymph nodes seen both sides. So make it more suspicious rather than just a systemic cause. And MRI demonstrate diffuse enlargement of the breast and the breast edema more on the right side, as well as patchy areas of bilateral non-mass-like enhancement, signifies that there is underlying breast disease. And throughout, we can see that there is pericardial thickening and enhancement and mediastinal and pericardial lymph nodes in the MRI. So that means it raises suspicious of lymphoma versus metastatic disease, extensive metastatic disease, and also the lymph node. And this is her chest X-ray, demonstrate the widened mediastinum with lobulations and lymphangiectatic spread, as well as left pleural effusion, okay? And the CT confirm all these findings, and the mediastinal necrotic enhancing lymph node, and it was the case of secondary breast lymphoma. This patient, one of interesting case, okay? She was She's a 72-year-old lady post-open heart surgery. She developed left breast ulcer. She presented with left breast ulcer. Okay, so she had been investigated with mammosonogram in 3 institutions, reported as unremarkable apart from the ulcer in the left breast, and even the ulcer not reported in the just in the clinical. She had left breast ulcers, and they have sent the patient for a dermatologist to evaluate for the skin ulcers. Unfortunately, that dermatologist was in our institution, and again, he has sent the patient. He started with rescan the patient or send the patient directly to radiology to exclude any underlying. He ignored the previous report and sent her again to be evaluated for the breast ulcer. One of really challenging cases and a lot of teaching point in this case. The patient had been seen by the technologist, and she came and told me this patient, she has nothing in her breast. Okay, and if you look for the mammography here, you can see there is some asymmetry. Okay, there is asymmetry compare. She has fatty breast, but the right breast, I can see this asymmetry at 12 o'clock. It was not seen in the contralateral. So I'm not sure what is going. Is it a residual island or there is a lesion at this location? I need to clarify by ultrasound, going and targeting this location. And I can see here focal area of skin thickening, which was corresponding to the site of ulcer. So I need to clarify also to target this area to see what is going on. And I went and I targeted the same location seen on mammography to clarify it by ultrasound. Regarding that asymmetry, I could appreciate these 2 lesions. The 2 lesions were isoechoic to the surrounding fat, but surrounded by thick-ringed, irregular, thick-ringed. And this one, it is even 3 centimeter lesion. Okay, it is 3 centimeter, and this is 2.5 or something. Okay, that is the first one. It was proven to be cancer. Okay, and the other area, the area of skin ulcer. So here, this is the skin ulcer. We can see it. There are something below this is skin. There is something pulling. There is tethering of this skin. There is pulling of this skin, and there is shadowing here. And architectural distortion, some, very minimal, but there are some echo, Doppler echoes, okay, seen here. So what is going on? With some angulation, we could appreciate this is speculated hypoechoic mass with, it is superficial, okay, with these spicules too long, extending into the skin and pulling the skin. But what about this ulcer? It's definitely not a fungating. It is not, it is a superficial ulcer. The dermal layer of skin intact. So this is not a fungating tumor, but it is indirect effect of the tumor. And as you know, the Skirras type, okay, of cancer interrupting because of the fibrotic effect interrupt the vascularity. And usually, if we can see the vascularity within such lesion, it will be minimal vascularity, or we can see the vascularity at the periphery and the center, the core of the tumor, no vascularity. The penetrating vessel end at the border of the lesions because the fibrotic effect of the tumor at the core interrupting this new vascularity. And because it is superficial and interrupting the vascularity, that resulting in ischemic necrosis of the decreased vascularity of the overlying skin and ischemic necrosis. And this is a benign ulcer, not a malignant ulcer, due to effect of the underlying serous tumor. Okay, this is another entity regarding scar carcinoma. And if you look here, it is difficult for us to tell if there is a scar carcinoma or there is no scar carcinoma. And usually we depend on the follow-up comparison with the previous, okay? In the follow-up, we compare with the previous. And here we look for this case. Which one is first? If this is the first and this is the second, there is progression. But if this is the first and this is the second, so there is the regression of skin edema as well as the asymmetry. Post-operative changes have been regressing, and that indicate regression of these findings are reassuring, and that is it. This is the same ultrasound demonstrate area of fat necrosis of scarring, okay, in the previous image, and that is the regression on the follow-up indicative of just post-operative changes without suspicious features. This is X-ray of post-operative lady presented with palpable abnormality. 50-year-old had a lumpectomy. At the site of lumpectomy, she had typical dystrophic type of calcification. What is we have to give this patient chance of short-term follow-up, though it is typically benign. Why? What do you think the reason that I gave this lady a short-term follow-up? Any suggestion? Okay, I gave her follow-up because I have no baseline mammogram, and I have seen this dystrophic calcification interrupted here. This part and this part. Yes, it can be arise like that, okay? It can arise one dystrophic here and the other one here. But I'm not sure if there is something in between interrupting this growth, okay? Or growing and interrupting that calcifications. So if you have a dystrophic calcification at the site of post-operative scarring, on the follow-up, if that dystrophic calcification get interrupted or displaced, it is a suspicious features. Okay, that means there is something growing below this dystrophic calcification and either displayed or fragmented this dystrophic calcification. So since it was the first time to present with this palpable abnormality, yes, I have to make sure the palpable abnormality due to this developed dystrophic calcification, or there is the dystrophic calcification, it was there already, and there is something growing on this, start to fragmenting this dystrophic calcification and is the cause of the underlying palpable abnormality. Okay, I have bonus cases. Do you like it? The remaining few cases are, do you like it? Or shall I stop?
Yes, you can proceed.
Okay, thank you. Okay.
Mostly, boss.
Okay, this lady, okay. Yes, this lady, she had these images, okay, and presented with acute left breast pain. This is her right breast, and this is the left breast pain side, inferior medial breast, where she has breast pain. it is obviously here we can see there is diffuse edematous changes that reduce valvular differentiation with overlying thickening. But we don't know what is the cause of that focal edema or regional edema. Okay, it was a regional edema extending into the remaining part of the breast, but it was more intense in that location where she experienced pain. And she had this appearance on her right breast. What do you suggest to be the cause of that edema? Okay, let me show you her previous mammogram. This is her previous mammogram. So, can you suggest? Can you give a suggestion for the diagnosis now? Can you see this one? What is this? In the inferior medial breast, she had an oil cyst, and that oil cyst ruptured and result in diffuse inflammation in her breast. So the lesson here, to reach a diagnosis, you have to go and search in the file of the patient for previous study to compare and explain. And we found, I have missed the ultrasound, even the ultrasound image for that cyst in the previous study. She had bilateral multiple fat necrosis, chronic fat necrosis, forming oil cyst. That oil cyst get ruptured and result in acute fat necrosis in her left breast. Okay? So that this edema is not related to breast cancer, I mean, okay? Not related to breast cancer. It is not only to prove the breast cancer, but we have to exclude breast cancer. This lady, she had silicone implant, single chamber silicone implant, presented with left breast pain. Can you suggest the diagnosis? So she presents with pain and a swollen left breast. We have to exclude breast cancer as a cause of her clinical problem. What is going on? This is the left and this is the right breast. T2 and T1. Again, T1, T2. Axial. This is the left and the right. What is the difference between the two? Anyone expert in the breast is available here? Anyone has experience in such type of cases?
I'm not
Okay.
experienced.
Huh?
I suggest implant rupture or كده.
You suggest implant rupture. Which type of rupture if you suggest implant rupture? What is
extra.
Oh, extra. Okay. What is going on exactly here? What is the sign you have seen here?
Linguine sign.
No, this is not a linguine sign. I can see the implant is well expanded, okay? The implant, but it is pushed by this remarkable, very prosthetic fluid. This is subcapsular fluid, a seroma, a large seroma, okay? If you compare, yes, it is normal to see small fluid around silicone implant, okay? You can see small fluid. But this remarkable amount of fluid or seroma is pathological, is not a normal. And if you look for the breast itself, this is edematous. The breast here, there is edema, okay? Diffuse breast edema. Can you see it here? Can you see the amount of fluid compared with the other one? And can you see the edematous changes can you see here, even in the fat, non-fat suppressed, and even in the fat suppressed, if you compare it with the contralateral one. So I'm dealing with large amount, okay? And let me show you the next post-contrast study. Here you can see the post-contrast, and you can see the subfibrous, okay, periprosthetic fluid or seroma. Okay, this is the fluid. The fluid is simple, not enhanced, no septations, which are very important. Okay, there is no septations, not enhancement, there is nothing. But look for the diffuse edematous with enhancement of the breast parenchyma, overlying skin, as well as enhancement of the capsule. The capsule significantly enhanced and thickened. Compare it with the contralateral breast. Can you see it here? This is the axial. Can you see how it is thick here? And what is the differential diagnosis of such findings? The differential diagnosis. What could it be?
Breast implant associated.
What?
Breast implant associated plastic breast implant associated anaplastic large cell lymphoma.
Excellent. Well done. Who is talking?
زولة كبيرة في العمر شوية بس.
لا مرحبا مرحبا. Who's talking? Rabab Al
Rabab.
Hassan. Oh,
Yeah.
thank you very much. Thank you, Rabab. Yes, that is why while I was describing this lesion, I said that this fluid is simple, okay? No septation, no nodularity, no enhancement. All of these, okay, just to make it to try to exclude the associated, and the patient implant is not about 3 or less than 5 years. Okay, this is also one important point. Okay, that makes the possibility of anaplastic lymphoma associated with implant less likely, but we have to consider it. We have to consider it in our differential diagnosis, and that we report it as implant infection, and the patient receive antibiotics and it get improved. It was just implant infections, and after improvement, they remove the implant. Okay, surgically remove the implant. And as you mentioned, it is important, very important, okay, to consider the primary non-Hodgkin lymphoma with implant, and usually the seroma, it will not be just a simple seroma. Most of the time associated with complexity, at least septations. Very unlikely to be just a simple free fluid like in this case. And also another alarming features is 10 years or more. If the patient has the implant for 10 years or more than that, then it will be alarming and we have to exclude it. And if there is any enhancement within that fluid, it will be suspicious. There is also a late periprosthetic seroma. This is one of the differential diagnoses, just idiopathic seroma. Okay. Another bonus, can you see any abnormality in this mammogram? This is a young lady presented with a tender periareolar swelling. Shows she has breast swelling. We have to exclude breast cancer. But from her symptoms, we suspect more inflammatory process. Can you see that lump? Can you see it in this mammogram? Can I show it to you? This is the ultrasound. It was areolar abscess. Okay. It was an areolar abscess. Retrospect. Now, can you see it? That is the lesion. Okay. It is low density here. It is superficial with subtle adjacent skin thickening. Very subtle. Okay. And this is a gift from one of my colleagues. It was not my case, but it is really interesting case. Patient with a palpable abnormality. Okay. Any patient presented with palpable abnormality, we have to exclude breast cancer. The appearance here, it seemed to be like what? Suggesting what? That is the interest. Suggesting lucency within capsule, subcapsular
Hamartoma.
lucency. Yes, suggesting hamartoma, but can you see? Not very typical of hamartoma. Can you see this? Cyst and something moving like that. It can be hamartoma, even on ultrasound, but the diagnosis was a hydatid cyst. The interest here, it was a hydatid cyst. It is very challenging to differentiate such a case from other tumor lesions of the breast, especially hamartoma. However, it should be included in our differential diagnosis of breast lump for patients living in endemic areas. Another interested cases, this is not related, not relevant, but it's interesting. The relevance here is only within these all multiple lesions, we have to be cautious, okay, to exclude breast cancer. Because I have such type of patient, but unfortunately, I mentioned the same patients having a breast cancer arises within this الهلمانة بتاعت multiple bilateral nodules دي. All these bilateral numerous or innumerable nodules. What is your differential diagnosis in this case? And what is associated with that? The clue for the diagnosis is seen in this image. What is the clue in the CC view? Can I show you the ultrasound? It might give a clue. This is the ultrasound.
Can I
have you seen such type of cases, Dr. Rabab?
I saw it في الخليج honestly. I saw it في الخليج لأنه الناس كانوا بيمشوا تايلاند يعملوا الحكاية دي.
Yes. You got it. Yes. Yes. So this is
free silicone injection.
This is free silicone injection. And the clue here, you can see the adjacent fibrotic reactions and the appearance of snowstorm appearance. These are small, it seems to be cysts, but are not a typical cyst. Okay, these are silicone granulomas, so obscuring the background breast. This is my patient. Okay, can you compare with a normal breast here? These are normal, fatty, and normal. This is fatty breast, so this is normal glandular breast. But can you see here the image? Snowstorm appearance completely mask the normal breast parenchyma, and here, if I have shown this, you can get it immediately because the silicone granuloma within the lymph node is very typical with this snowstorm appearance. This is silicone injection granuloma. Thank you very much, and I hope you enjoyed and you benefited from this session, and sorry for taking you too long.
Thank you very much, Dr. Rabab. It was a very enjoyable session, very interesting cases indeed. So thank you very much. We're going to take just few questions because we don't have enough time. We're going to take some questions for Dr. Yahya. Any questions for the nuclear medicine lecture? Only 1 or 2 questions allowed.
Okay, if you allow me, I'll ask Dr. Yahya one question, if nobody else have question.
Sure. Welcome, Dr. Rabab.
Okay, Dr. Yahya, you have shown one case of lymphoma, okay, PET scan demonstrate a lymphoma, and uptake in the breast as a physiological uptake, but it was asymmetric. The left breast taking uptake more than the right. So how can I take such type of challenge? How you could differentiate that breast not involved even by the lymphoma?
Dr. Yahya, can you hear us?
Not there?
I can't see Dr. Yahya. Maybe he's having connection problem because he was just here.
Okay.
Okay.
Anyone have question for me? You are welcome if you have question. Since Dr. Yahya is not there, he might join. Until he join, if you have any question regarding my cases, you are very welcome to ask me if I can help you.
Okay, any questions? All right. If there are no questions, this was the last session of our symposium. We're going to have our closing remarks of this radiology symposium will be presented by Dr. Wishah. Welcome, Dr. Wishah.
Welcome. بسم الله الرحمن الرحيم الحمد لله رب العالمين والصلاة والسلام على رسول الله صلى الله عليه وسلم. So we are coming to the end of our symposium. And before we all head out, I would like to thank everyone who showed up today and yesterday evening. You really came through and made this event a smashing success. Let me take a moment to express our gratitude towards all who participated in making this event possible. We would not be able to do what we do without your participation. We highly appreciate your patience till the end of the symposium. I would like also to give a shout out to our event team who accept the challenge and put together everything from scratch till this great moment. Exceptional thanks and appreciation to our main partner, Sidro, and to all those who were working silently, leading this way to success. A special thanks for the facilitators for their great job. We are looking forward for more and more collaboration and partnership in the future. Deep thanks for our speakers. I want to say to them, we have enjoyed the nice presentations and found it very beneficial and interesting. And for our colleagues from other specialties, thank you very much for attending, participating, and enriching the discussion, as you always do. Let me thank in particular Dr. Aida, Dr. Nadia, Dr. Omar Al-Farouq, and all others colleagues. With your interaction and active participation, we were able to articulate a great discussion today. And for all of you, we know that breaking away from your busy day can be challenging, but it is always great to see you come together for time away from the daily grind. Thank you very much. And let me just summarize the 2 days symposium. On the first day, we have gone through the interesting lectures about missed breast cancer at different modalities and how to overcome it. On this day, we went through many amazing presentations and fortunately saw many new faces, ensuring that this field is on safe hands, alhamdulillah. We learned today about BIRATS and how to apply it on mammography and ultrasound. We got a good idea about screening mammography, and also got oriented to the role of ultrasound in screening of high risk and young patients. We also went through the role of MRI in screening in the same group of patients. We had a look at an approach to the symptomatic breast based on UK guidelines and practice. And we were also introduced to the role of nuclear medicine in breast cancer management through an interesting lecture. And lastly, we learned about multimodality approach for breast cancer cases. It also was very nice and interesting. On a personal level, all lectures were so beneficial, valuable, and informative. So let me say some take-home messages. Always update yourself and your knowledge by keep on learning. And it's time to update and activate guidelines in breast cancer management in our country. And also, I want to highlight the significance of multimodality approach in breast diseases and the significance of multidisciplinary approach in breast cancer and the beauty of teamwork. The final message is that do not miss our amazing multidisciplinary symposium coming up soon before the end of this month. Lastly, let me convey an exceptional thanks and appreciation extending from me and from you to the key person in this event and in the SSBI. And let me say, coming together is a beginning, keeping together is a progress, working together is a success. Dr. Rabab, you gave us the true meaning of success. Thank you very much, everyone, and see you soon.
Thank you very much. Thank you, everyone, for attending.
Thank you for all of you. I am so happy. I'm so happy, and I hope the MDT symposium will be much better than this. يعني زي ما انت قلتي أيادينا مع بعض. We can do a lot. Thank you very much. قبل ما تختم معلش بما إنه دكتورة رباب يعني our guest for the first time أعطوها فرصة إنها تقول اسم شنو ده كلمة إن وجدت. وبما إنه دكتورة عايدة يعني جزاها الله خيرا ما قصرت وده كما عهدناه منها في كل الأكتيفيتيز بتاعتنا. هي مننا ولينا عرفتي ودايما مشجعانا. فبرضو أدوها يعني short talk. فالرباب, you are welcome if you are here, and then Dr. Aida to finalize the talk.
Thank you very much, Dr. Olay. Thank you very much for inviting me, and it's an appreciated effort of everyone who participated in organizing this. We have a lot to thank first. طبعا الحمد لله سبحان الله سخر لنا هذا. A few years ago we wouldn't be able to do this and participate from all over the world. Learning is now easier than ever, I think, in history. So I will encourage everyone to keep learning. As Dr. Rosha has said, transfer of knowledge is easier with these online activities. So participate, engage, ask questions, and I would say suggest topics that you want to hear about, you want to learn about. And I trust that organizing committee will find a suitable person to deliver that for you. Thank you very much, everyone.
Thank you, Dr. Rabab. ومن هنا